So imagine for a second that you are just going about your normal life. Maybe you just got back from a tropical vacation, or maybe you live in a bustling city down in South America.
Right. Just a normal Tuesday.
Exactly. And then suddenly you are just hit by this absolute freight train of a fever. I mean, we are talking severe chills, the kind of headache that makes light physically unbearable, and your entire body aches so deeply it feels like it's, in your marrow.
Oh, yeah. It's an overwhelming inflammatory response.
It's terrifying. But then, after about a week, the fever breaks. You wipe the cold sweat off your forehead, you take a deep breath, and you think, okay, I survived that.
You think you're in the clear.
Right. You go back to work, you go back to your family, you try to catch up on everything you missed, and then, inexplicably, like 2 weeks later, out of absolutely nowhere, the exact same freight train hits you all over again.
Yeah, and it is just a phenomenal psychological blow. I mean, you think you've navigated your way out of the woods, but the forest has essentially sprouted up right around you again overnight.
Wow.
The physical toll is bad enough, obviously.
Yeah.
But the mental exhaustion of that recurrence is staggering.
I just want to sit with that reality for a second. Imagine the psychological torture of thinking you've survived a brutal illness only to be thrown right back into it just when you let your guard down.
It's cruel, really.
It is. And this isn't some hypothetical scenario. This is the current on-the-ground reality of the Oropouche virus, which is often called OROV.
Right, OROV.
It's a pathogen that most people had literally never heard of a year ago, and it has completely exploded across the Americas. I mean, we're looking at well over 10,000 cases in 2024 alone.
Yeah, and knowing how these things are tracked, that number is almost certainly a massive undercount.
For sure, because the surveillance mechanisms we rely on are just, they're buckling under the sheer pace of this.
Right.
We are watching a virus actively rewrite its own rulebook in real time, and public health infrastructure is scrambling to catch up.
Oh, totally scrambling.
And the reason we know this is because the warning lights are flashing across the entire global health dashboard right now. We don't just have one or two isolated papers here.
No, we have a mountain of data.
Exactly. So our mission today on this deep dive is to serve as your shortcut to becoming exceptionally well-informed about this emerging threat.
Which is so important right now.
It really is. So to do that, we are looking at these urgent memos flying between the CDC and state health departments in Alabama, Georgia, and New York.
Right.
Plus, we've got panicked clinical reports coming straight out of rural Brazilian emergency rooms. We are cross-referencing a highly detailed meta-analysis published in PLOS Neglected Tropical Diseases with a living systematic review from the Pan American Health Organization.
A lot of material.
It's a ton, but we're going to cut through the panic, decode the medical jargon, and equip you with the hard facts about what Oropouche actually is.
Because if you look at the historical data, this pathogen was perfectly content to stay in its ecological niche for decades.
Right, it's not new.
No, not at all. It was discovered in the 1950s. It just simmered quietly.
Mm-hmm.
But what we are seeing now is basically a masterclass in biological adaptation.
Yeah.
It's a virus exploiting new environments, leveraging new vectors, and finding its way into incredibly dense human populations.
I want to start exactly there, in the 1950s, because the origin story of this virus is wild. According to the World Health Organization data, Oropouche was first identified in 1955.
Right, down in Trinidad and Tobago.
Yeah, in a village called Vega de Oropouche. But I mean, virology in the 1950s was not what it is today.
Oh, not even close.
They didn't have PCR machines where you just swab someone's nose and get a genetic sequence an hour later. Finding a new virus back then was like finding a needle in a haystack in the dark, using incredibly rudimentary tools.
It required painstaking foundational epidemiology. I mean, back in the mid-20th century, organizations like the Rockefeller Foundation were running these massive global virus hunting programs, and they would set up laboratories in tropical regions, like the Trinidad Regional Virus Laboratory. And to find a virus, they often had to take blood samples from febrile patients, or even capture wild mosquitoes, grind them up. Grind them up and inject that material into the brains of sentinel laboratory mice.
Just to see what happens.
Exactly. To see if the mice developed neurological symptoms. If the mice got sick, they knew there was an active pathogen in that sample. It was a grueling analog process of isolation.
So they isolate this virus in 1955, and for the longest time, it operated in what's called a sylvatic cycle.
Yes, sylvatic.
And sylva is just Latin for forest. So this is a jungle cycle. It's circulating completely independent of human beings.
Humans weren't even part of the equation.
Right. The primary vertebrate hosts are non-human primates, certain bird species, and this detail always gets me pale-throated sloths.
I know, the sloths are a very specific detail.
It's just quietly bouncing between sloths and the insects that bite them in the Amazon basin. It doesn't eat humans at all.
Well, the sylvatic cycle is essentially an ecological holding pattern. You know, the virus, the sloths, and the insect achieve a state of equilibrium.
They balance out.
Right. The virus replicates enough to be transmitted, but not enough to wipe out its host. Because obviously a dead host is a dead end for the virus.
Makes sense.
So it is a very delicate, ancient dance.
But something disrupted the dance. I mean, the virus transitioned from that quiet, low-stakes rehearsal in the forest to an urban cycle.
It definitely broke out.
It moved to the chaotic, high-stakes opening night on a global stage. And the actors bridging that gap, the ones carrying the virus out of the jungle and into the cities, are the vectors.
Right, the vectors are the key.
Now, when I hear tropical vector-borne disease, my brain immediately goes to mosquitoes. Dengue, malaria, Zika. It's always a mosquito.
Right, that's what everyone assumes.
Yeah. And while certain mosquitoes can carry Oropouche, the primary villain in the story is a biting midge called Culicoides paraensis.
Which fundamentally changes the entire public health equation. I mean, a midge is a very, very different adversary than a mosquito.
How so?
Well, the most critical factor is its physical morphology. An adult culicoides midge is remarkably small. We are talking about an insect that is often less than 3 millimeters long.
3 millimeters? That's smaller than a sesame seed.
Considerably smaller.
Yeah.
And because they're so diminutive, our standard lines of defense are rendered completely useless.
Wow.
Yeah. The World Health Organization's Health Alert specifically highlights that standard mosquito bed nets, which have been the cornerstone of global vector control for decades, do not work against Oropouche.
That is wild.
The midges simply fly right through the holes in the netting without breaking a sweat.
That is such a terrifying visual. I mean, it's like trying to use a chain link fence to keep out a sandstorm.
That is exactly what it's like.
We've spent billions of dollars in decades distributing these standard nets across the globe, and suddenly, against this specific threat, they're just expensive window dressing.
Pretty much.
So how does a community even pivot when their main shield is obsolete?
Well, you have to fundamentally redesign the shield.
Yeah.
The WHO guidelines stipulate that you need ultrafine mesh netting.
Which sounds hot.
Oh, it is. It severely restricts airflow and is incredibly uncomfortable to sleep under in a tropical climate.
Yeah, I bet.
Or you need netting that is heavily treated with residual chemical insecticides, meaning the midge dies the moment it lands on the fabric before it even attempts to pass through.
Okay.
But beyond that, you have to move away from relying on personal barriers and focus on large-scale environmental modification.
Right, attacking the breeding grounds. But from what I read in the sources, midges don't breed like mosquitoes.
No, they don't.
Like, mosquitoes need standing water, an old tire, a bucket, a puddle. Midges are different, Mark.
Very different. Midges breed in moist, decaying organic matter. So leaf litter, compost piles, the muddy banks of a drying river, agricultural waste.
Oh, wow.
Yeah. So in a dense peri-urban area where the city fringes meet the encroaching forest, eliminating every patch of damp, rotting leaves is a logistical nightmare. It is virtually impossible to eradicate their habitat.
And we can clearly see the midges are winning this battle. I mean, by late 2024, the outbreak had exploded past 10,000 confirmed cases across Brazil, Bolivia, Colombia, Cuba, and Peru.
It moved incredibly fast.
And because human beings get on airplanes, the CDC had to issue alerts because we saw at least 52 travel-associated cases reach the United States. You know, Florida, California, New York.
Right, it crosses borders easily.
But this begs a massive neon-flashing question. If we discovered this thing in 1955, why did it wait 70 years until 2024 to explode like this? What broke the equilibrium of that forest cycle?
It is a confluence of ecological drivers, and human activity is right at the center of it. Let's look at the mechanisms of habitat encroachment. We were seeing rampant, unprecedented deforestation in the Amazon basin to make way for agricultural frontiers. When you clear-cut the forest, you displace the natural hosts.
Right, the sloths and monkeys.
Exactly. The sloths and the primates are gone, or are greatly reduced in number. So the midges, which are highly adaptable and incredibly hungry, suddenly find themselves without their primary food source.
So they just switched to the next available warm-blooded meal, us.
Yep.
We basically bulldozed their grocery store and built a neighborhood right on top of it.
Exactly.
Oh.
And compounding that habitat destruction is the reality of climate change. Remember, insects are ectothermic.
Meaning cold-blooded.
Right. Their internal temperature and metabolic rates are entirely dictated by the environment.
Yeah.
So a rise in ambient temperature of just 1 or 2 degrees profoundly alters the life cycle of a midge.
Wow, just 1 or 2 degrees.
Yeah, it accelerates their breeding cycle, meaning you have exponentially more midges. And crucially, it also shortens what virologists call the extrinsic incubation period.
Okay, I want to break that down. Extrinsic incubation period. That's the time it takes for the virus to develop inside the insect, right?
Precisely. When a midge bites an infected animal, the virus goes into the midge's gut. It then has to replicate, escape the gut, and travel to the midge's salivary glands before that insect can infect the next person it bites.
That sounds like a long journey for a virus.
It is. In cooler temperatures, that process might take 2 weeks. Now, if the midge only lives for 10 days, it dies before it can pass the virus on.
I see.
But if the climate warms, that viral replication speeds up. The extrinsic incubation period might drop to 5 days. Now, a midge that lives for 10 days has a 5-day window where it is an active flying bioweapon.
That is a brilliant and terrifying explanation. The warming climate literally turns the midges into faster, more efficient delivery vehicles for the virus.
Yes, unfortunately.
So let's follow that delivery vehicle. We've established the vectors are nearly invisible and their numbers are swelling. Let's talk about what actually happens inside the human body once that tiny midge lands on your skin and takes a blood meal.
Well, once the virus is introduced into your bloodstream, you enter an incubation period of roughly 3 to 10 days. During this time, the virus is hijacking your cells, replicating silently. You feel absolutely fine. And interestingly, the epidemiological data suggests that about 40% of people infected never develop symptoms at all.
Wait, really? 40%?
Yes, their immune system clears it quietly. But for the roughly 60% who do become symptomatic.
Oh man, when it hits, it is a localized apocalypse in your body. We have a remarkably detailed meta-analysis published in PLOS Neglected Tropical Diseases that analyzed 806 patients with confirmed Oropouche.
It's a very robust study.
Yeah, and the symptom profile is aggressive. 100% of the patients developed a sudden, severe fever. 95% had a debilitating headache.
Right.
72% reported myalgia, which are severe muscle aches, and 69% had violent chills.
Those are the classic hallmarks of an acute febrile illness. But what you are experiencing isn't just direct damage from the virus. You are experiencing your own immune system's scorched earth defense strategy.
Scorched earth, that's a good way to put it.
Yeah. When your white blood cells detect the viral RNA, they release chemical messengers called inflammatory cytokines.
Cytokines. I've always pictured them as chemical flare guns that the immune system fires off to call for backup.
That's a great way to visualize it. The problem is, when too many flares are fired, the resulting inflammation causes massive collateral damage.
Right.
The cytokines travel to your hypothalamus, which is the thermostat in your brain, and reset it to a higher temperature to try and essentially cook the virus to death.
So that's the fever and chills.
Exactly. And those same cytokines also sensitize your pain receptors, making your nerve endings hypersensitive.
Oh, so that's why everything hurts.
That is why your muscles ache so profoundly. Your body is creating a hostile environment for the virus, but it's excruciating for you.
That makes total sense. But looking at the PLOS data, there were 2 specific symptoms that really stood out to me because they seem so distinct.
Which ones?
59% of patients experienced severe anorexia and 56% experienced retroorbital pain. Now, when I see the word anorexia, my mind immediately jumps to the psychological eating disorder.
Of course.
But in this clinical context, it means something entirely different, doesn't it?
Yes, completely different. In an acute viral infection, anorexia refers to a profound systemic loss of appetite. It is a phenomenon of metabolic triage.
Triage.
Yeah. Digesting food is an incredibly energy-intensive process for the human body. So when you were fighting off a systemic viral replication, your body diverts every available ounce of metabolic energy to the immune system.
Wow.
Your brain literally shuts down the desire to eat and slows down gastrointestinal motility just to conserve energy for the cellular war being waged in your bloodstream.
That is fascinating. And the retroorbital pain, the pain behind the eyes?
Ah, yeah. That is a very specific throbbing ache located deep behind the eyeball, and it typically worsens dramatically when the patient moves their eyes from side to side or up and down. The extraocular muscles, the tiny muscles that control eye movement, are becoming inflamed. It's a clear indicator that the viral load and the systemic inflammation are heavy enough to start affecting the connective tissues and the peripheral neurological pathways in the orbital cavity.
Okay, so you are suffering through this. Let's walk through the timeline. Day 1, you get a bite from a tiny midge you didn't even notice.
Right.
Day 6, the sudden high fever, the chills, the muscle aches, and that searing eye pain hit you. You are absolutely miserable. But you rest, you hydrate, and by day 10, the fever breaks.
You start feeling better?
Yeah, you feel weak, but you are recovering. And this brings us right back to the hook of our deep dive, the signature defining trait of Oropouche.
The recurrence, the relapse phase. This is what separates Oropouche from almost every other common arbovirus.
It's so unique.
The clinical alerts from both the Alabama Department of Public Health and the CDC explicitly highlight that up to 70% of symptomatic patients experience recurrent symptoms days or even a couple weeks after the initial illness seemingly resolves.
70%. I just keep coming back to that number. It's not a rare complication. It is the statistical norm for this disease.
And the medical community is still struggling to understand the exact physiological mechanism driving it.
Hey.
Why does the fever return?
Do they have any ideas?
There are two leading hypotheses. The first is that the virus is biphasic. It might retreat into what we call a privileged reservoir in the body.
Like where?
Perhaps the central nervous system or the synovial fluid in the joints. Places where the initial immune response can't quite reach it. So it hides, regroups, and surges again.
Okay. And the second hypothesis?
The second is that the virus is actually gone, cleared by the immune system, but the immune system itself fails to stand down.
Oh, an overreaction.
Yes, it's a delayed secondary inflammatory overreaction. The cytokine flare guns keep firing at shadows, basically.
Wow.
But regardless of the cellular mechanism, the clinical reality for the patient is identical, and it is devastating.
I try to put myself in the shoes of a primary care doctor dealing with this. A patient comes in, their fever has broken, and they are asking if they are cured.
It's a tough conversation.
How do you look at a patient and say, well, you're fine right now, but there is a 7 in 10 chance you're going to be bedridden again next week? You run the risk of sounding like a complete alarmist, but you have to prepare them for it.
It requires incredibly nuanced patient education. You have to explain that the initial recovery might merely be an intermission.
An intermission, wow.
Yeah. The psychological fatigue of that anticipation is heavy. And from a broader epidemiological perspective, the economic disruption is profound.
Right. Think about the economic and workplace impact. You have a massive local outbreak. 70% of your affected workforce, factory workers, teachers, nurses, they call in sick.
Massive disruption.
They recover, they return to work for a week, and then abruptly, 7 out of 10 of them call in sick all over again. It would completely shatter the operational continuity of local economies and strain healthcare staffing to the breaking point.
Which brings us to the chaos happening inside the emergency room itself during that very first visit. When a patient walks in on day 6 with a high fever, a terrible headache, and muscle aches, the attending physician is faced with a massive diagnostic puzzle.
Because it looks like everything else.
Exactly. Those generalized symptoms perfectly describe almost every notorious tropical disease on the planet.
The arbovirus identity crisis. Based on the PAH reports, Oropouche perfectly mimics the clinical presentation of the big three: dengue, chikungunya, and Zika. If you look at them side by side on day 1 of the fever, they are virtually indistinguishable.
And this overlap creates a treacherous diagnostic minefield, because how you treat those diseases and the complications you watch out for are radically different.
This is where the public health alerts from the New York City Health Department and the Georgia Department of Public Health reveal something truly frustrating about our current system.
Yes, the testing protocols.
This part of the source material genuinely blew my mind. According to these official health department alerts, a doctor standing in an ER cannot simply order an Oropouche test for a patient.
No, they can't.
The testing is heavily gatekept by the state. The protocol literally requires a doctor to test the patient for dengue and have that test come back negative before the state health department will even authorize a laboratory to run an Oropouche test.
It is a rigid process of diagnosis by exclusion. You have to prove what it isn't before you are allowed to check what it might be.
But why? I mean, if we have 10,000 cases of Oropouche, why make a doctor jump through bureaucratic hoops while a sick patient is sitting right in front of them?
Well, there is a harsh, pragmatic public health logic to it. Dengue is vastly more common on a global scale, and more importantly, dengue can be rapidly fatal if it is not actively managed. Dengue can lead to something called hypovolemic shock. So public health infrastructure is designed to rule out the known immediate killer first. They don't want a doctor hyper-focusing on a novel Oropouche case and accidentally missing a lethal case of dengue.
Let's unpack hypovolemic shock so we truly understand the stakes of that triage. Hypo meaning low, volemic meaning volume. What is actually happening to the patient's blood?
In severe dengue, the virus damages the endothelial glycocolex.
The what?
It's the delicate, microscopic inner lining of your blood vessels. The blood vessels literally become porous. They turn into sieves.
Oh, that's bad.
Yeah, the plasma, the liquid portion of your blood, begins to leak out of the vascular system and into your body cavities, like your lungs and abdomen.
Wow.
As the fluid volume in your veins drops rapidly, your heart no longer has enough pressure to pump blood to your vital organs. That is hypovolemic shock. And without immediate intravenous fluid resuscitation, the organs fail and the patient dies.
Okay, so ruling out dengue is a literal life or death priority, but getting a dengue test back takes time.
It does.
And if you have to wait for that negative result and then get prior approval from a high-level facility like the CDC or New York's Wadsworth Center to finally run the Oropouche test, aren't we fighting this outbreak blindfolded?
Absolutely. From a real-time epidemiological standpoint, it creates a massive lag in surveillance data.
Yeah, I bet.
By the time an Oropouche case successfully navigates that gate-kept laboratory process and is officially confirmed, weeks have passed.
So they might already be better.
Or they might already be in their relapse phase. Or the local midge population might have already bitten them and spread the virus to a dozen neighbors. It practically guarantees that our global maps and case counts are vastly underrepresenting the reality on the ground.
So if the lab results take weeks, how do doctors in the trenches tell these big cats apart in the dark? Because dengue, Zika, chikungunya, and Oropouche all look like massive threats with big teeth.
It's really difficult.
You need specific clues, a roar versus a purr, to know what's in the room with you.
This is exactly what the Pan American Health Organization, PAHO, sought to answer in their Living Systematic Review. They aggregated vast amounts of clinical data to find statistical discriminators.
And what did they find?
First, they confirmed that fever and headache are completely useless diagnostic tools, because everybody gets those.
Right.
However, they found two very strong statistical tells for Oropouche. The first is a symptom called odynophagia, which is the medical term for painful swallowing.
Painful swallowing, okay.
A patient with Oropouche is 3.2 times more likely to experience severe pain when swallowing than a patient with dengue. The second tell is severe abdominal pain, which is 2.5 times more likely in Oropouche.
Painful swallowing and stomach cramps. That is a fascinatingly specific profile. And what points away from Oropouche?
The PHA data shows that if a patient presents with a very severe, widespread maculopapular rash, or if they have debilitating symmetrical joint pain, specifically in the distal joints like the wrists and ankles, that points much more strongly toward chikungunya or dengue. Oropouche simply does not trigger severe joint swelling or major rashes at the same frequency.
And as we discussed with the hypovolemic shock, if a doctor guesses wrong, the consequences are disastrous.
Yes, absolutely.
If they assume it's Oropouche but it's actually dengue, they might send a patient home with instructions to rest, completely missing the onset of plasma leakage, and the patient goes into fatal shock in their living room.
A tragic mistake.
Conversely, if they assume it's dengue but it's Oropouche, they might aggressively pump the patient full of IV fluids, which can cause fluid overload and respiratory distress if the vessels aren't actually leaking. The stakes in that emergency room are unbelievably high.
And this high-wire diagnostic act is occurring against the backdrop of healthcare systems that are already stretched incredibly thin.
Yeah, no kidding.
Picture a rural clinic in the Amazon basin, or even a swamped urgent care in Miami, trying to parse out whether a returning traveler's headache is the start of a mild Oropouche relapse or the precipice of severe dengue hemorrhagic fever.
It's impossible. And while the mild symptoms and the relapse rate are exhausting enough, the real shockwave hitting the medical community recently has been what happens to the small percentage of patients who develop severe complications.
The severe edge.
Right, because Oropouche isn't always just a two-part fever. Sometimes it crosses a terrifying line.
The current statistics suggest that less than 5% of infected patients develop severe manifestations.
Which is still a lot of people when you have tens of thousands of cases.
Exactly. These rare cases generally fracture into two categories: hemorrhagic disease and neuroinvasive disease. Hemorrhagic symptoms, while alarming, are relatively straightforward. Spontaneous bleeding from the gums, severe epistaxis or nosebleeds, and petechia, which are tiny, pinpoint hemorrhages under the skin.
But it's the neuroinvasive side that has everyone on edge. We have 2 specific peer-reviewed case studies in our source material that chart a very disturbing evolution of this virus's capabilities.
Let's start with the older, a 2019 case study published in PubMed Central.
Yeah, tell me about that one.
This case involves a 28-year-old male in Ribeirão Preto, Brazil. He had recently traveled to the Amazon region. He presented at the hospital with the standard fever and headache, but it rapidly progressed.
Into what?
He developed profound confusion, active visual hallucinations, photophobia, and nuptial rigidity.
Let's pause there. Nuptial rigidity is a dangerously stiff neck. If a patient comes into an ER with hallucinations, a fever, and a neck so stiff they can't touch their chin to their chest, a doctor's alarm bells are screaming meningitis, right?
Immediately, it is the classic triad of central nervous system infection. The doctors performed a lumbar puncture, a spinal tap, to draw cerebrospinal fluid.
Okay.
They ran a PCR test on that spinal fluid, and it came back positive for Oropouche viral RNA. His official diagnosis was aseptic meningoencephalitis.
Let's really break down that term, aseptic meningoencephalitis, because it sounds like a mouthful, but it describes exactly what the virus is doing.
Let's split the word. Meningo refers to the meninges. These are the 3 layers of protective membranes that encase your brain and your spinal cord.
Got it.
Encephalitis refers to the actual parenchyma, the tissue of the brain itself. Aseptic simply means that when they cultured the fluid in a petri dish, no common bacteria grew.
Ah, so it was viral.
Yes, the inflammation was viral, not bacterial. So the virus was actively inflaming both the protective wrapping of the brain and the brain matter itself.
But how does a virus that is injected into your arm or your leg by a tiny midge end up inflaming your brain tissue? I always thought the brain had a VIP security detail to prevent exactly this.
It does. It's called the blood-brain barrier. It is a highly selective, nearly impenetrable border formed by tightly packed endothelial cells and astrocyte end feet.
Okay.
It is designed to allow oxygen and nutrients in, but keep pathogens out. The terrifying reality of Oropouche in these rare cases is its neurotropism, its ability to breach that security detail.
How does it get past the guards?
Viruses have evolved incredibly insidious mechanisms to cross the blood-brain barrier. Some use a Trojan horse method.
Like sneaking in.
Exactly. They infect immune cells, like macrophages, that are naturally authorized to cross the barrier to patrol the brain. The virus hides inside the cell, crosses the border, and breaks out once inside.
That is genius.
Alternatively, the virus can directly infect and destroy the endothelial cells making up the barrier itself, literally punching a hole in the wall.
Wow.
Once the virus is inside the central nervous system, it replicates rapidly. The local immune cells in the brain, the microglia, launch a massive counterattack. And that resulting inflammation inside the confined space of the skull causes the pressure to rise, leading to the stiff neck, the confusion, and the hallucinations.
Thankfully, the documentation shows that the 28-year-old man in 2019 eventually made a full recovery.
Yes, he was lucky.
But fast forward to 2024, amidst this massive explosion of 10,000 cases, the virus seems to have unlocked a new, much darker achievement. We have a silo preprint detailing a recent case in Ceará, Brazil, involving a 48-year-old woman.
And reading this case report is harrowing.
It really is.
This 2024 case represents a profound and highly alarming escalation in clinical severity. This patient didn't just get brain inflammation. She developed a severe autoimmune condition known as combined central and peripheral demyelination, or CCPD.
Let's unpack demyelination. A lot of people might have heard that term in relation to multiple sclerosis, but let's visualize what's happening. Instead of the classic copper wire analogy, I like to think of the human nervous system as a vast, high-speed fiber optic network. Your brain is the main server, and the nerves are the delicate glass cables carrying light signals to every muscle in your body.
That's a great way to picture it.
For those signals to travel cleanly and at high speed, the glass cables are wrapped in a protective, reflective cladding called myelin.
That is a highly accurate visualization.
Yeah.
Demyelination is the systematic destruction of that reflective cladding.
Scary stuff.
In CCPD, the immune system becomes profoundly confused by the viral infection. Through a process called molecular mimicry, the antibodies that were generated to attack the Oropouche virus mistakenly identify the body's own myelin sheath as a foreign invader.
Oh no!
Yeah. The immune system begins stripping the cladding off its own fiber optic cables.
So the signal from the brain bleeds out into the surrounding tissue. The message gets corrupted or lost completely before it reaches the muscle.
Exactly.
And because this is combined central and peripheral, It means her immune system was attacking the cables inside her brain and spinal cord, and the cables running out to her arms and legs simultaneously. What did that actually look like for this 48-year-old woman?
The clinical deterioration was rapid and devastating. She developed ascending flaccid tetraparesis.
Okay, translate that for us.
Ascending means it started in her lower extremities. Flaccid means a complete loss of muscle tone. Tetraparesis means paralysis of all 4 limbs. The paralysis climbed up her body until she could not move her arms or legs. Furthermore, she developed facial paresis, paralyzing the muscles in her face.
And it attacked her vision as well, right?
Tragically, yes. She developed retrobulbar optic neuritis. The immune system attacked the myelin sheaths, specifically on her optic nerves, the thick cables connecting her eyes to her brain. Her vision rapidly deteriorated until she was practically blind, able only to perceive vague shadows and light changes.
She went from a bug bite to a fever to being totally paralyzed and practically blind. That is an absolute nightmare.
It is a worst-case scenario.
How does the medical team even attempt to stop an autoimmune cascade that violent?
They utilized an aggressive intervention called plasmapheresis.
How does that work?
This is a procedure where the patient is hooked up to a machine that literally draws their blood out of their body, runs it through a centrifuge to separate and discard the plasma, which contains the rogue myelin-attacking antibodies, and then returns the red blood cells mixed with a donor plasma or substitute fluid.
So they're basically cleaning her blood.
They are physically filtering the friendly fire out of her bloodstream.
Did the plasmapheresis work?
Only partially. She underwent 5 grueling sessions. The case report notes that after 90 days of observation, her vision had improved slightly from shadow perception. But she still had profound, persistent visual deficits and required significant assistance just to walk.
That's heartbreaking.
The structural damage to the myelin network was incredibly severe and may take years to heal, if it ever fully does.
I want to focus on why this is happening now. In 2019, we saw meningitis, which is bad, but it's a known, understood complication of neurotropic viruses.
Right.
In 2024, we are seeing temporary paralysis and blindness caused by the immune system eating its own optic nerves. The researchers who authored that 2024 paper did a phylogenetic analysis. They sequenced the virus's family tree.
Yes, they did.
And they identified a brand new lineage of the virus. So the question is, are we seeing this virus actively adapt its genetic playbook to become more virulent? Or is this just a grim numbers game, where if you infect 10,000 people, the 1 in 10,000 rare genetic freak accident finally shows up on a doctor's radar?
That specific question is currently the subject of intense, heated debate within the virology community right now.
Which side are you leaning towards based on the sources?
Well, to understand the first possibility, viral adaptation, we have to look at the structure of Oropouche. It is a segmented virus. Its genome isn't one long continuous strand. It is broken up into distinct segments.
I picture that like a deck of cards.
Exactly. When a host is infected by 2 slightly different strains of a segmented virus at the exact same time, those viruses replicate inside the same cell. During the assembly process, they can accidentally swap whole segments of their genome.
They drop their decks, pick them up, and shuffle them together.
This process is called genetic reassortment. The new 2024 lineage identified in the paper is a reassortant. It has a newly shuffled genetic deck.
And the terrifying unknown is whether that new genetic shuffle gave the virus a master key to trigger these severe autoimmune demyelination events like CCPD.
Precisely. Does the new protein structure of this reassortant virus look so similar to human myelin that it aggressively triggers that molecular mimicry? We don't have definitive laboratory proof yet.
And the other option.
The alternative explanation, as you pointed out, is epidemiology of scale.
Right, the numbers game.
When a virus is restricted to a few hundred cases in isolated Amazonian villages, a 1 in 10,000 complication remains invisible. But when it explodes into dense urban centers and affects tens of thousands of people across multiple countries, the rarest, most devastating statistical tails of the bell curve suddenly manifest in emergency rooms.
So it could be a bit of both.
The clinical consensus right now is that the reality is likely a synergistic combination of both factors.
Yeah.
A slightly more reactive viral strain exploiting a massive new pool of human hosts.
The idea that a bite from a midge the size of a sesame seed could trigger a shuffled virus that tricks your own immune system into destroying the insulation on your optic nerve, it is a staggering amount of biological dominoes falling.
It truly is.
But the virus's ability to breach barriers in the body, whether it's the blood-brain barrier or the myelin sheath, leads us directly to what is arguably its most devastating and urgent consequence.
Yes.
we need to talk about what happens when this virus affects the most profoundly vulnerable patient population of all.
We are talking about pregnancy and vertical transmission. This is the inflection point where public health messaging shifts from standard preventative advice to urgent, high-level alarms.
In 2024, health authorities documented for the very first time conclusive evidence that the Oropouche virus can pass directly from a pregnant mother to her developing fetus.
A huge, tragic shift.
And the clinical outcomes being reported out of Brazil right now are nothing short of heartbreaking. The alerts detail confirmed reports of fetal deaths, spontaneous miscarriages, and severe congenital abnormalities, specifically microcephaly in newborns.
We must address the biological gravity of these findings. Vertical transmission means the pathogen has successfully crossed the placental barrier. Now, the human placenta is a biological marvel. It is an incredibly robust, highly complex fortress specifically evolved to protect a developing fetus from the myriad of maternal infections circulating in the mother's blood.
It's meant to be impenetrable.
It utilizes a layer of fused cells called the syncytium trophoblast to create a virtually impenetrable physical and immunological wall.
But clearly, the wall has a weakness.
Yes. Certain pathogens have evolved specific molecular tools to bypass this fortress. In medicine, we group the most notorious of these under the acronym T or She infections.
What does that stand for?
Toxoplasmosis, other agents like syphilis, rubella, cytomegalovirus, and herpes simplex. These pathogens can cross the placenta, infect the fetus, and cause catastrophic developmental anomalies.
And now, Oropouche is on that list.
Based on the 2024 data, it appears Oropouche has developed the capacity to join that devastating list.
And when it crosses that placental barrier, it causes microcephaly. Let's explain the mechanics of that.
Microcephaly is a condition where a baby's head is significantly smaller than expected for their age and sex. This happens because the brain has either not developed properly during pregnancy or has prematurely stopped growing.
Why does it stop growing?
Well, if the Oropouche virus crosses the placenta and it exhibits the neurotropism we discussed earlier, that specific affinity for invading and destroying neural tissue, it targets the fetal neural progenitor cells.
The stem cells.
Right. These are the stem cells responsible for building the architecture of the developing brain. The virus infects these progenitor cells, uses them to replicate, and destroys them in the process. Without those foundational building blocks, fetal brain development is literally halted in its tracks.
We have to acknowledge the immense haunting parallels here. For anyone living in Latin America or anyone working in global public health, the word microcephaly immediately triggers a deep visceral trauma. We are talking about the Zika virus epidemic of 2015 and 2016.
The memory of Zika casts a long, dark, incredibly heavy shadow over the current Oropouche outbreak.
It was devastating.
During the height of the Zika epidemic, thousands of babies were born with profound, life-altering brain damage across Brazil, Colombia, and the wider Americas. The anxiety and sheer terror for expecting parents in those regions today, as they hear these early reports about Oropouche, is immeasurable. They are watching a nightmare scenario seemingly replay itself.
I keep thinking about the impossible position of public health communicators right now. Given the absolute trauma of Zika, how do officials communicate this new threat to expecting parents without triggering immediate, paralyzing societal panic?
It's extremely difficult.
How do you balance the need for extreme caution with the scientific reality that research is still ongoing? Because if you read the WHO systematic review closely, it explicitly notes that while Oropouche viral RNA was definitively found in fetal tissues and umbilical cord blood, the epidemiological investigations are still rigorously trying to definitively prove causation versus correlation.
It is the most delicate and perilous tightrope walk in all of epidemiology. You cannot, under any circumstances, wait for a perfectly clean, peer-reviewed, multi-year longitudinal study proving absolute causality before you issue warnings.
Because waiting costs lives.
Exactly. Waiting for perfect data costs lives and results in irreversible congenital harm. You have to act aggressively on the strong clinical correlation. This is why the World Health Organization and the CDC have rightfully and decisively issued Level 2 travel health notices.
What does a Level 2 travel health notice actually mandate for the public?
It is a formal, highly escalated warning. It explicitly counsels all pregnant people to seriously reconsider any non-essential travel to areas with ongoing documented Oropouche outbreaks.
Just don't go.
Right. It further states that if travel to these regions is absolutely unavoidable, the traveler must employ the strictest, most uncompromising bite prevention strategies available. It is a clear directive that the risk to fetal development is considered severe and credible.
And what about the infants born to mothers who contracted the virus during their pregnancy? What are the medical protocols for them?
The guidelines released by the CDC and the American Academy of Pediatrics, the AAP, are incredibly rigorous and demanding.
What do they require?
Infants born to mothers with confirmed or suspected Oropouche infection during pregnancy require comprehensive, specialized evaluations by a healthcare provider immediately at birth. But the vigilance doesn't stop in the delivery room.
Right, because neurological damage might not be obvious on day one.
Exactly. The AAP guidelines mandate specialized neurological, auditory, and developmental screening at every single subsequent well-child visit for months and years to come.
Wow, that's a lot of monitoring.
Pediatricians are instructed to look for subtle signs of delayed developmental milestones, hearing loss, or latent neurological deficits that might only become apparent as the child attempts to walk, talk, or interact with their environment. The burden of monitoring is immense.
The stakes are just astronomically high. With the risks this severe, from a 70% relapse rate to temporary paralysis to the threat of congenital brain damage, the immediate practical question for anyone listening to this deep dive is, what do we actually do if we get it, and how do we stop it from spreading in the first place?
Let's start with the hard, uncomfortable truth about clinical treatment. There are no vaccines available for Oropouche. None.
None at all.
Furthermore, there are no specific antiviral medications that can target and kill the virus in your bloodstream. The medical care is entirely supportive.
And supportive care is medical shorthand for rest, aggressive oral hydration, and managing the pain and fever.
Yes.
But this brings us to what is arguably the single most critical life-saving warning buried in all of our source material today.
Like what?
Both the Alabama Department of Public Health and the Georgia Health Alerts feature this warning prominently in bold text. If you suspect you have Oropouche, or even if you just have an undiagnosed fever after traveling, you must only use acetaminophen to reduce your fever.
Really, acetaminophen.
Aspirin and all other NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen, Advil, Aleve, or naproxen are strictly, categorically forbidden.
This is a matter of basic pharmacology intersecting disastrously with viral pathology.
Can you break that down?
NSAIDs are brilliant medications. They're highly effective at reducing inflammation and blocking pain receptors. However, a well-documented systemic side effect of all NSAIDs is that they inhibit an enzyme called cyclooxygenase, or HEOX. By inhibiting COX, NSAIDs prevent platelet aggregation.
Let's translate that. Platelet aggregation. That means the drug physically stops your blood cells from sticking together to form a clot. It thins your blood.
In layman's terms, yes, it acts as a mild blood thinner. Now, let's connect that to what we discussed earlier about how arboviruses damage the human body.
The leaky blood vessels.
Right. Remember that less than 5% of patients with Oropouche and a significant percentage of patients with dengue develop hemorrhagic manifestations. The virus is actively attacking and damaging the endothelial cells, that delicate inner lining of your blood vessels.
The vessels are becoming leaky sieves.
Precisely. The virus is poking microscopic holes in your vascular system. Your body's natural defense against this is to send platelets to patch the microscopic leaks.
Okay, I see where this is going.
If your blood vessels are actively leaking due to viral damage, and you have just ingested a medication that chemically prevents your blood from clotting, you are overriding your body's patching mechanism.
That's horrifying.
You are creating a biological recipe for severe, uncontrollable, and potentially fatal internal bleeding.
I really want to emphasize why this is so dangerous on a practical, everyday level.
Yeah.
Think about your own habits. You have a pounding headache, your muscles ache, your joints are on fire. Reaching into the medicine cabinet for ibuprofen or Advil is an automatic, thoughtless reflex for millions of people.
It's muscle memory.
Right. The public health messaging around strictly using acetaminophen, Tylenol, is critically urgent because it requires overriding an ingrained cultural habit to prevent accidental hemorrhagic shock. Reading the label on your medicine cabinet could literally save your life if you've recently been to an outbreak zone.
The automatic habit of reaching for an NSAI must be aggressively interrupted through public awareness campaigns. It is a vital tenet of harm reduction in arbovirus outbreaks.
Moving from the dangers of treatment to the massive headaches of testing. We touched on the state gatekeeping earlier, needing a negative dengue test first, but the actual laboratory protocol for getting a definitive gold standard confirmation of Oropouche is a logistical nightmare all on its own.
It's incredibly complex.
The CDC testing guidelines require what are called paired serum samples.
Yes. To confirm a recent active infection through serology, A single blood draw is often insufficient. The CDC requires an acute sample and a convalescent sample.
Okay, what's the difference?
The acute sample, which can be blood serum or cerebrospinal fluid, must be collected within the first 10 days of illness. This is when the viral RNA might still be detectable or when the early response IgM antibodies are just beginning to form.
And the convalescent sample?
That second sample must be collected a minimum of 2 weeks later during the patient's recovery phase. The state laboratory, or the CDC, then places the two samples side by side to look for a specific, measurable rise in neutralizing antibodies.
How do they do that?
They do this using a highly complex, labor-intensive laboratory procedure called a plaque reduction neutralization test, or PRNT.
Let's explain the PRNT test, because it sounds like sci-fi, but it's actually a brilliant piece of biology. How do they physically see if your antibodies are fighting the virus?
Well, in a high-security lab, scientists take a layer of living, healthy cells in a petri dish. They mix a sample of the live Oropouche virus with the patient's blood serum. If the patient has developed specific antibodies against Oropouche, those antibodies will bind to the virus and neutralize it. They then pour this mixture over the living cells.
And then they just wait.
A few days later, they look at the dish. If the virus wasn't neutralized, it kills the cells, leaving visible dead zones or plaques. By counting the plaques, they can precisely measure how effectively the patient's immune system neutralized the virus.
That is wild.
It is incredibly accurate, but it takes days to grow and requires a highly specialized laboratory environment.
And beyond the lab complexity, just think about the real-world logistical hurdle of getting those paired samples. We are talking about transient populations, tourists who have flown home to different states, or local residents utilizing severely underfunded, overcrowded public health clinics in rural areas.
It's a huge ask for a patient.
Exactly. Getting a patient who is already feeling better or worse, a patient who is suffering through that miserable 70% relapse and is too weak to travel, to commute back to a clinic weeks later for a second blood draw. It is an almost insurmountable barrier for robust data collection.
And to make matters worse, the CDC specifies these samples must be refrigerated and shipped as Category B biological substances with frozen cold packs.
Maintaining a cold chain shipping route out of the Amazon basin to a state lab is a Herculean task.
Which is exactly why our epidemiological tracking is so flawed. This logistical gauntlet acts as a profound barrier to accurate surveillance. It guarantees that our global map of where this virus is currently spreading is inherently delayed, deeply pixelated, and missing massive swaths of data.
Which brings us to the final and most crucial line of defense: prevention. If we can't easily or quickly test for it and we have absolutely no medication to cure it, we have to stop the transmission on the source.
We have to stop the bite.
Right. We talked about how standard mosquito bed nets fail entirely against these tiny midges. If I'm a listener heading to the Caribbean or South America next week, using EPA-registered repellents like DE, picaridin, or IR 3535, and wearing long, loose clothing sounds like the standard, obvious advice.
It is, but it's only part of the solution.
Right, because on a macro level, how does a local community fight an insect vector that breeds in almost any damp organic matter and slips effortlessly through standard window screens?
It is an arduous uphill battle that requires sustained, community-wide mobilization and funding. It goes far beyond personal insect repellent.
So what does that look like in practice?
It necessitates structural architectural changes. Retrofitting homes with ultra-fine mesh screens on all windows and doors. It involves intensive, relentless environmental sanitation.
Like cleaning up leaves.
Organizing community drives to clear out leaf litter, drain mud puddles, and properly manage agricultural and compost waste near residential zones. It requires robust municipal support for targeted chemical residual spraying on the interior and exterior walls of homes where the midges rest.
Wow.
It is a highly resource-intensive strategy that demands constant, unwavering vigilance from both the government and the citizens.
It sounds like we are dealing with a virus that requires us to fundamentally redesign how we build our homes and interact with our environment if we want to keep it at bay.
Absolutely.
Let's take a breath and summarize the incredible, sobering journey we've taken today. We started our deep dive in 1955, looking at a quiet, obscure virus simmering in a Trinidadian forest, bouncing harmlessly between sloths and midges.
A different world entirely.
Fast forward to 2024, driven by deforestation and a warming climate, and it has evolved into a blaring global health headline.
We have unpacked the unique, exhausting reality of its 70% symptom recurrence rate, exploring the physical and economic toll of that double hit.
Yeah, that relapse rate is just brutal.
We've navigated the treacherous diagnostic chaos in emergency rooms, where Oropouche perfectly mimics dengue, leading to high-stakes triage decisions regarding hypovolemic shock.
And we examine the terrifying cellular mechanisms behind its severe neurological complications, visualizing how it breaches the blood-brain barrier and triggers autoimmune demyelination. Not to mention breaking down the pharmacological danger of taking common NSAIDs during an active infection.
Crucial point there.
And perhaps most soberingly, we looked closely at the critical urgent warnings issued for pregnant travelers, exploring the devastating parallels to the Zika epidemic and the tragic reality of vertical transmission and microcephaly.
It's a lot to take in.
Connecting this directly back to you, the listener, whether you are prepping for a tropical vacation, whether you work in the healthcare field, or whether you are just insanely curious about the invisible forces shaping global health dynamics, understanding Oropouche is no longer niche academic knowledge.
It affects us all.
It is a live, evolving shortcut to being genuinely well-informed about the world's rapidly changing infectious disease landscape. The climate is shifting, the agricultural frontiers are expanding, the insect vectors are moving faster, and the ancient viruses are shuffling their genetic decks to adapt.
Which leaves us with a final lingering question to ponder long after this deep dive ends.
Oh yeah, go ahead.
If a relatively obscure virus discovered in the 1950s can quietly simmer in the Amazon basin for 70 years, only to suddenly alter its transmission dynamics, spread rapidly across international borders, and develop severe, unprecedented neurological complications in 2024. How many other mild, forgotten viruses are currently circulating in the wild, sitting quietly in a forest cycle? Just 1 degree of warming or one genetic reassortment away from becoming tomorrow's global health emergency.
Wow. It really makes you wonder what else is waiting in the wings. The next time you get a sudden fever, you'll hope it's just a clean break, like a simple line on an X-ray. But in the warming world of emerging tropical diseases, you might just be waiting for the sequel. Thanks for joining us on this deep dive.